This is an MS Views and News program, and today we are live for our first time in Memphis, Tennessee. We have an audience here, live in person, and we got you all live online as well. Next, I want to thank our sponsors for today's program. Today's sponsors, we have Bristol-Myers Squibb, we have SANOFI Genzyme, we have EMD SERONO, and we have GENENTECH. And our exhibit sponsors today, we have Janssen. Janssen is a division of Johnson & Johnson, and Janssen has a nice MS medication out there. You'll have to look them up or come back to our website to find out who they are and what they do. We also have Bristol-Myers Squibb is also a sponsor. All right, today's program, I'm not sticking around for long, all right? Today's program, Dr. Samuel Hunter from Franklin, Tennessee. He's the director of the Advanced Neuroscience Center in Franklin, and he will be here presenting on many different things, including shared decision-making, understanding new MS treatment options, a little bit about this, a little bit about that, and he's going to take it away. And let's welcome him up here, all right? Thank you.
Thank you. Nice to meet you. Stuart's, I've worked with Stuart and the people at MS Views for a long time. I think it's a very important resource for us in multiple sclerosis. The good thing about people with MS, for the last 30 years, they've been a market. And so the people that make medications have invested money in better medications and in helping you understand your illness. We're going to talk today about MS decision-making, and we're going to have plenty of time for questions at the end. So it's really important to think about your questions as we go so you don't forget, and then we keep it rolling and we get through as many as possible. So I work with two outfits. One's a nonprofit called NeuroNexus, and the other is Advanced Neurosciences Institute. It's our practice and research institute. And we do a lot of things for MS. We also do other kinds of neurology, but MS keeps us busy. What we're going to talk about today is what shared decision-making means. And we're going to try to help you understand some of the changes in MS treatments. We now have somewhere in the mid-20s of MS therapies that are approved. Some of these are like the other treatments. Some of them are relatively new. And we're going to try to put this in the framework of understanding how your immune system protects you and what's going on in COVID, how you get yourself comprehensive care for your MS, because it's increasingly difficult between insurance companies, the government, access to medications, trying to manage in the world and live your life with a chronic immune illness. We're going to talk a little bit more about cognitive problems in MS and how to measure multiple sclerosis. This is important both to keep track of you, to help you with your disability, and to help make decisions with your team of professionals who's caring for you. All right, I want to dedicate this to a very precious person who was born and raised in this area named Ruth Woodall, who passed away a couple months ago, who worked on our board and was a person with MS and really quite a leading and award-winning person in science and technology education in the state. And she fought really valiantly for a couple months with COVID. All right. So let's start with shared decision-making. What does it mean? When you talk to a doctor, shared decision-making, we always share decisions. I tell them what to do and they do it. And we used to call that, patriarch kind of approach. But I think it's best defined as agreeing with everybody knowing what's going on, where we've been and where we want to go. With treatment. And this is a conversation. It's not a simple conversation. People value different things. Actually, doctors and patients value some of the same things. They're driven by fear, convenience, and cost. And I think the brain is a machine designed to find the easiest way to get things done. Sometimes that's the right way to get things done. But every neurologist is going to do things a little bit differently. But it is a free country, and you have freedom of speech, and you can express your feelings and try to get understanding and accomplishments of what is important to you. When you boil it down in medicine, it boils down to risks and benefits. What do we get for doing something? And this has really wide spectrum. I have individuals who are so concerned about possibility of having some problem from a treatment that they don't want to go and do anything, and they suffer the consequences of that. And I have other people that are so scared of the things that are going wrong with their MS that they'll take what are very extreme risks with treatment, or sometimes end up with people or treatments that are ill-advised because of their concern for trying to control their MS. That said, some of the safest medicines may have unpleasant side effects. The good thing is they are not necessarily dangerous. And some of our medications that have a lot of different risks, those risks may be quite small, and they may be otherwise have little unpleasant side effects so that people's quality of life isn't impacted. But if I was to tell everybody who has had frustrations with their health care in multiple sclerosis, one thing is doctor's advice is cheap, okay? Disability is not cheap. So you're well off getting more perspectives and asking to get more perspectives. But in general, if a team of professionals is working with you, who's trying very hard, meeting with you, listening to you, this is a good group of people. Probably the unfortunate reality of MS is what you lose will not be gotten back. And this is, we learned this very early in MS. There are a few exceptions to this rule, but in practice, this is the way it is. And what's, I would say the corollary of what's lost is not regained is what's bad often gets worse. So that is a problem. I have other lectures online with MS Views where I talk a lot about MS symptoms, and I would suggest you watch those. I'm not going to revisit all MS symptoms today, but there's quite a lot of information from me and my colleagues who have presentations that are archived on the YouTube channels and so forth. So let's talk about a few decision-making episodes that are, I think, illustrative and things I've had multiple times. And the first is I want to get a stem cell transplant. And what are stem cell transplants? Stem cell transplants are giving you very large doses of chemotherapy to completely destroy your immune system and then giving you some own cells that have been harvested back to you to essentially reboot the immune system. This is an old technique. It was developed for the purpose of treating cancer, and it's been used rarely with some immune diseases for over 30 years. And it's been brought to the forefront because of some celebrities who've recently gotten these treatments. And let me tell you, MS can be very annoying to people, and it can cause them a lot of anxiety because things that are both temporarily and in the long term disrupted in their life. And we have patients who come in and say, hey, I'm tired of this. Selma Blair went and got a stem cell transplant in Mexico. I want to do that. And well, that's what this patient has seen and says that would be a good solution for me. But what she actually doesn't understand what's going on with that whole process. And just, I like to throw in the example of her. She'll say, oh yeah, and I got this really great timeshare in Florida. So, things can look really good and turn out to be very bad for you. And what she doesn't know is that aggressive treatment is not always appropriate for a person. There are a very tiny fraction of people where that kind of treatment would be appropriate. But what she also doesn't know is that you're going to lose your hair for years. It's never going to be the same again. You lose your life on occasion with those kinds of treatments. And that centers who do this abroad, cheap, do it that way because they make money, they give you less medicine so you're not so sick, and they don't have to put you in the hospital, and that reduces your risk and increases your convenience, but it also results in a lot of failure of treatment, or it's essentially a temporary treatment. And you still have bad hair and a risk of cancer from the treatment and a risk of death from the treatment. And they aren't there to give you fair balance. If you show up and say, "Hey, give me a stem cell transplant. Here's $30,000," they'll say, "Sure," whether it's a good idea or not. So, this is a legitimate discussion to have with some patients about whether this is a way to treat that. In other countries that have publicly funded healthcare systems, it actually can be a cost-effective way to treat multiple sclerosis in those people who have really severe active early multiple sclerosis. But other people, it doesn't work so well. And in the United States, the people who've done the most of it have largely been shut down by the government because they didn't do it safely or properly. There are a few centers that do it well. They do very little of it. First of all, it's hard to get approved. And second of all, it's not safe. And we have lots of safe, highly effective medicines for MS. All right. The other thing I hear a lot is, I don't want to get PML. What is PML? We'll talk a little bit more about PML later, but it's a rare brain infection caused by a weak immune system. Normally, if we step away from MS, this is a rare problem. It's 1 in 80,000 people. They almost always have cancer or HIV. And it's listed in all your prescribing information for almost all the effective, highly effective MS medicines, not the oldest ones, but pretty much anything that we go to really try to get good control of MS lists it. Even when it's never happened, it's listed as a risk by the government. Probably happens someday. But in practice, there's really only one medicine that's a risk in a meaningful amount. And so this is a discussion to explain to the patient, she doesn't want a bad complication. What is the reality of the risk, her risk of that complication? Well, if she's on this drug, Tysabri, which is a highly effective drug for MS, and incidentally, people feel great while they're taking it, the risk is over 1% a year of getting this life-threatening, catastrophic, sometimes fatal complication. What is it with all the other MS medicines? Well, if they were just on Tysabri, it's about 1 in 1,000. If they've never been on Tysabri or not recently on Tysabri, the risk is between 1 in 5 and 20,000. So just a few times higher than what it is for the next person on the street. In reality, your odds of getting killed driving to the doctor for an appointment is probably higher than that. So you want to look at risks and benefits, and if you need a medicine that's relatively safe and well tolerated and controls your MS, as long as you can sleep at night knowing that something might go horribly wrong, just like you could win the lottery tomorrow from buying a lottery ticket, you would want to do that. So once you explain and understand what the risks are and what the benefits are with the physician, then it's pretty easy to make an agreement. And this goes on a lot in MS because treatments may not be tolerated. You may have some kind of minor complication that would require changing it. You may not be able to get certain treatments because you have other health conditions. And every one of our medicines in multiple sclerosis has advantages and disadvantages. And they all have the benefit predominantly of what never happens. So when you feel bad with MS and you're on a good medicine, everything can be normal. Are doctors going to try to make your symptoms better? Yes, that's a whole different lecture. We have those lectures online. We're talking about preventing your MS from getting worse quickly. All right. So the other is people with an earnest desire to treat their MS without pharmaceutical medication. There are very rare people who get by without treating their MS. Most of those people after 10 or 20 years are not walking well. The hardest thing to help people understand, I believe, early in the course of MS is that you haven't seen anything yet. You don't understand how bad this is going to be. And so in great hope that doing everything possible otherwise would help them, people often forego or delay dramatically treatment during a time when it's highly effective and would help them for the rest of their life. There's a book by a doctor who claims to have a diet that is very good for MS. I don't doubt that it's good for you, the diet. I know it's not adequate treatment for MS, and she does too, because she has MS, and she got chemotherapy for MS before she went on her diet. and the diets are going to help. They're not going to cure anything. The other lifestyle matters, like getting your sleep right, getting your stress right, doing yoga, and having a healthy work-life balance. These are all good for you. They're good for your mental health. They're good for your physical health, but they're not going to change the fact that you have MS. And MS isn't always a consistent problem. It can pop up from time to time. But what's lost is not regained, generally. So you can't always come to an agreement together as a patient and a physician. And sometimes that leads to patients not returning. Sometimes that leads to them changing doctors to someone who does these holistic kinds of medical approaches. And they may not realize until it's quite advanced in their disability that they're not able to cope with it and seek treatment. And one of the problems is the way the medical system works and the insurance system works is if you haven't had the first steps, they're not going to let you have the later steps, the ones that are highly effective, without you going back to zero. And you're maybe at a time in your illness where going to zero is pretty fruitless. And this is very frustrating for everybody, but this happens a lot. So one of the importance is getting experience, and using drugs to control your MS is having experience in drugs to control your MS. It gives a physician much more leverage with someone who's paying for your medicine to use higher priced or riskier medicines that are going to get you more benefit. And some of our best medicines that can produce improvement are very hard to get unless you've had one or two other cheaper experiences. And when we say cheap, we mean costs less than $100,000 a year or less than $50,000 per year. And medicines are starting to go generic, and some of them are good medicines that go generic. They're not always great for everybody. They're not always well tolerated or able to be used in every MS patient. But if those medicines work well for you, yes, go for them. But you have to always remember in MS that the benefit is what doesn't happen. Just the same as treating your diabetes or high blood pressure or cholesterol. The benefit is what doesn't happen of treating a condition. All right. So in order to treat MS and to understand what's going on, we try to measure it. And the measurements aren't made day to day. They're made over periods of time. Preferably when somebody with relapsing MS isn't in the middle of a relapse, it's usually kind of fruitless to do a lot of time and effort measuring things when you know they're bad right now. You want to get an idea of where they are over years. And it's important also to be able to measure MS so that when people aren't doing well, they become eligible for benefits like disability benefits or assistance in their employment, accommodations, school, things like that. There's a lot of things that you're able to do. There are medicines that insurers won't let us use unless we show by measurements that you need them and that you respond to them. So thinking is probably the hardest thing to measure. It's also the most expensive and time-consuming, but there are simple ways to get to that. MS isn't like the kind of problems people have when they're older with dementia. It's more like sleepiness or being drugged. People with MS often feel stupid, and they feel like they're having terrible time, and everybody notices, but actually it's just their thinking is slower. They make mistakes. They have to put a lot of effort into concentrating. People don't notice it as much as they do because of these things. It's the same as trying to work when you're tired or ill, or you've had a hard week, or you just had surgery or the flu. That's what it's like in the brain. It's very similar to that. The thinking is mostly invisible on an MRI scan. There are research ways to do it. that have been looked at. We have one class of medicines that's probably better at improving thinking than the other ones. This is called the S1Ps. I call it the depression, fatigue, cognition spectrum, because these medicines, when you look at them with different kinds of tools that we use to measure these elements, people with MS who are on them tend to improve over time, over months and years. And so it is mostly a result of things that are so microscopic you can't see them on an MRI. This is the connections between brain cells we call synapses, which go away when there's a problem in the brain. They don't go away, they just become a lot less. The immune system sort of eats them, turns on and eats them. And that's not good for your ability to think quickly and clearly. But there are also parts of the brain that actually shrink. These are called gray matter areas. They're the surface of the brain and the deep areas where the nerve cells are, because they're damaged by the inflammatory process. And then there are other things that can go wrong, many factors: sleep, mood, medicine, and so forth. Seizures that can affect people's thinking. Older MS patients get the same problems that everybody else gets, like stroke and dementia and epilepsy. All right, how do we measure MS? Well, we do it with a stopwatch. It's pretty easy. Nobody uses this anymore. Everybody uses their phone. But the simplest thing to measure a gait is have somebody walk 25 feet from a standing start and measure that. And that is actually a pretty good way. Now, once you start having problems with your gait, it usually gets worse, but this is a time-tested way to find things for MS. We actually have medicines that make people walk faster. They walk sometimes 20, 30, 40% faster on medication. But you still get where you're going. If you're walking slowly, you may use more energy. Neurologists use a very complicated scale, and this is, we call it EDSS. It was invented by a really brilliant doctor, and it's been revised over the last 50 years to give us many different dimensions of people's function. It's not very good for thinking, actually. We use other things for the thinking. We'll talk about them. It's like, are you normal? Can nobody tell you're normal? Do you think you're abnormal? Oh yeah, you're abnormal. Oh, you're really bad. That's kind of the cognitive scale here. That's not very helpful. We've got better scales than that. But many of the other dimensions are the same way. They have to do with strength, walking, coordination, sensation, bladder, and everything that goes on in your head. And then we come up with a number from 0 to 9 about how you're doing. There are actually a couple more. We don't use those because they're not very meaningful. But, they largely have to do on this scale with how far you can walk. Why is that? Well, leg function is a pretty good way to measure how bad the spinal cord is damaged, because it's the longest pathway. It gets damaged a lot in MS because it's anywhere in below your head that gets damaged is going to affect your legs, and many of the places inside your head are going to affect your legs. There is one very simple scale that we pass out to patients to see what they think their disability is. And this is a 0 to 9 scale that they can fill out themselves. And it goes from 0, I have no problems and no limitations, up through a number of levels of disability that, again, have a lot to do with your legs. But noticeable symptoms in your life that are minor and don't affect your lifestyle are a mild disability. Things that have limitations in other ways than walking affect you some more, and gait tends to affect people the most. And there's higher levels of disability where people are much less ambulatory, and getting around is a challenge for them. Now, looking at hands, there's a really good test for that. It's called a 9-hole peg test. You can look at it on YouTube. You can buy one online and see how to use it. It's basically a tray with 9 pegs, in a tray, and with each hand you put them in, it looks like a tic-tac-toe board in a board, and then you take them out again, trying to do that without dropping them, which slows you down, and it's timed. It takes about 20 to 30 seconds to do for people, and it's a good measurement of how good your hands are. And you do it with each hand. Of course, one hand's going to be better than the other. And this is a way that we use over many years to keep track how people's hands are doing. So cognition. I told you cognition's hard to measure. What neurologists do and what professionals who measure cognitions, who are called neuropsychologists, do are different. Neuropsychologists will take most of a day to do a number of functions and look very comprehensively at the brain. This is expensive, it's time-consuming, it's quite taxing, and we can take some shortcuts in the neurology office to try to get some of this information more quickly. What is the problem in MS? It's mostly processing speed and accuracy. Simple things are not a problem. People with MS usually talk a good game. They say, I can't find words. Nobody else notices. You notice because you have to struggle with it, just like you do when you're tired or drugged or sick, because that's the same effect that the MS has on the brain. But we can actually measure processing speed. We have you do something very simple, which is decode symbols in written symbols, and you call them out as you decode them. And it's just finding the symbol in a list and calling out which number it is. And that takes 90 seconds to do. We do it in an office. It's a very good indicator of people who have problems. And MS patients are slower and they make more errors. In children, actually, the girls are so much faster than the boys. It's incredible. It's like girls are way faster, but in adults, it's pretty similar. And we do it orally because that gets away from the writing aspect of it, which is hard for some people with MS. But you can do that too. They're not comparable. You have to stick to one or the other. And so over 50 in 90 seconds, 50 symbols decoded. That's normal. I have people who can do 60 who have MS, 65. I'm like, I don't know how they think so fast. But under 40 is low, pretty low. People usually have problems. Under 30 is very slow. And so this is a good way in that periodically we can assess people. There are similar tests of other kinds. People with MS complain a lot about their memory, but it's very different kind of memory problem that they have because they really remember things pretty well. And what they seem to complain about is how much effort they had to put into remembering things. And they are more forgetful. It's harder for them to make memories. But the kind of memory that we usually associate with memory loss of anyone is called anterograde. It's short-term memory. It's new memories that you're making, not old things you know. It's basically learning that you have trouble with. People with MS are frustrated by it and the effort. The tests that are usually done by primary care and neurologists, there's one called mini mental status test. They're not very good at picking up these problems. Why? Because people with MS have more time. You have more time in that kind of setting to think, and time fixes it. It's slow. There are tests that are timed and that are much more quantitative. They're not simple tests. They can be done in a neurologist's office, but they're not usually done in a neurologist's office. They're usually done by a psychologist. The California verbal learning tests, they sit there and they give you a list again and again. See how many you can keep coming up with off the same list. And then there are other ones that are figure-based or paper-based where you see a figure and you have to draw it, and these are hard. And anything that's more complicated, MS patients make more mistakes and don't do as well. And why is that? Because your brain's kind of functioning at a lesser efficiency, and you've actually lost some of the capacity because of the damage that's there. That's referring to things like atrophy that are in the brain. So there are lots of ways if people aren't functioning well, to document it. It's very important if people need disability benefits to get this kind of comprehensive matter before they apply for disability. The psychologists are not easy to access. They take time. They're in demand. The whole healthcare system hasn't been working well the last few years. But they can demonstrate that people with MS have problems that would impair their work. But they have to do the right tests. You know, if you wait and go to the disability people will do some 3-minute test and say you're fine. All right, how do you improve it? We're going to talk a little bit about how to improve your cognition. These work not only for MS, but for everybody. But testing helps kind of sort out what it is. I actually have an electronic system in my office that in 45 minutes and people clicking a computer mouse gives me a pretty good idea of how people are performing. It's not nearly as good as a neuropsychologist can do, but it's cheap and it's fast, and it gives me an idea about their paying attention, their memory, their ability to process information, and just sort of overall how much problems they're having. I think that's something that if your doctor has access to it, he should use. I think the most important thing with MS is always to treat your disease as aggressively as possible, as is reasonable, because that is going to save you more trouble in the future. Something people with MS often don't realize is that some of the medications that make other things better make your thinking worse. And the simple way to look at this is anything that makes you sleepy or makes you mouth dry is going to make your memory work worse and your thinking work worse. And some folks really like these medicines. They make other things feel good, and they don't realize how devastating they can be to your mental performance. And so having discussions with your physician about what these medicines are and what they're doing, things you take for pain, things you take for bladder, things you take for anxiety or tremor or dizziness, these are medications that can make your thinking much worse. This family of medicines we call sphingosine 1-phosphate receptor modulators, or S1Ps, are disease-modifying therapies that really help thinking. There's a couple companies that got products out here today that both have really impressive in helping this depression, fatigue, cognition spectrum over time for many people. It isn't a guarantee. It isn't something they're allowed to advertise or tell you because the government approves or doesn't approve certain claims about medication. But this family of medicines have been around for many years, and you see this routinely with many people. And again, getting to the problem early is really important. For many decades, we've known that keeping body temperature under control improves function in people with MS. In fact, NASA actually made a refrigeration suit for people with MS back in the 80s and 90s, where people wear a little refrigerated suit and carry their cooling unit around with them. That was back before we had anything that worked or any of the medicines that you hear about nowadays. But it really does work, and you know, if your family can tolerate the air conditioning set there and you can pay the bills. Alcohol it has effects on your brain, and some of these effects aren't good. A little alcohol periodically is not going to hurt you, might even be beneficial in some ways, but moderating alcohol use if you're drinking more than a couple drinks a day is really important. The old saying was that fish is brain food. It actually is true. So fish contains a few things if it's the right kind of fish. First of all fish is full of vitamin D. People with MS need vitamin D. It's just easier to take a vitamin D supplement than it is to eat fish. But the fish contains large amounts of oils called omega-3 fatty acids. And these are very important for calming down the immune system and protecting your brain from injury. You can get these from other sources if you're allergic to fish or averse to eating fish. But the simple thing is to eat one of these oily fishes, and it doesn't have to be expensive fish, tuna, salmon, herring, cod, 3 times a week. and that is a lot of omega-3. And they've actually demonstrated that the people who do that with MS, their brains are in much better shape than everybody else. All right. The other thing, the first thing you can do if you want to speed up your thinking by 10 or 15% is stand up. Automatically, instantly, your brain will work 10 or 15% faster. It's a neat trick. That's a very easy thing to learn to do. And the other end of that is exercise and physical activity makes your muscles make a hormone that helps rebuild the brain, makes new brain cells, makes the brain make better connections. This is really important in MS. It improves fatigue. It improves your thinking. It actually improves your mood, too. Now, MS fatigue is a lot like sleepiness, but it's not sleepiness. Cognition and fatigue are a lot alike. Everybody gets fatigued at the end of the day. Everybody has trouble thinking at the end of the day normally. But how can you look at this overall? Well, MS fatigue and cognition, it tends to follow body temperature. Your body temperature is lowest in the morning, and people are usually the best. It's highest in the afternoon, and people are usually the worst. It's very similar to your biological rhythm every day anyway. People tend to be worse in the middle of the day and get kind of a second wind in the evening. But sleep is very important because sleep problems add on to the brain dysfunction that you have with MS. And so there are a lot of reasons people have sleep problems. They may have trouble falling asleep. They may have trouble waking up in the middle of the night, either for no reason or because somebody's snoring, they're not breathing, their bladder's a problem, they hurt really bad, their legs are jerking, they may not even know that's what's waking them up. They have animals in their bed, or their spouse is disturbing the rest. So fixing your sleep is really important. If you're waking up in the morning feeling rested, your sleep is really good. All right. What's the other thing you have to fix? Well, most people with MS have problems with their mood from time to time. This is in partly because the immune system's interfering with the production and the distribution of immune chemicals, the neurochemicals that make you feel normal. Medicines in the antidepressant family are very safe and they're very effective for you. And there are such great ones now with minimal side effects. They're almost like fertilizer for your brain. So fixing your mood, if it's a problem, if it's beyond the capacity of your primary care or your neurologist, you see a mental health professional who knows how to do this. They're very good at finding things to do this. So I'll mention in the next slide a few things. Coffee is a miracle drug. Tea is the same, and green tea, the stronger the better. There is a limit to how much green tea you can drink in a day safely. It's really about 4 cups, but there is no limit to coffee or tea. Sugar is bad for you. Cream is bad for you, but coffee and tea are really good for you. All right. Oop, slides aren't running. There it is. Okay. So what about pharmaceuticals? Well, melatonin, which technically is not a pharmaceutical. There are drugs that are just like it, that are drugs that are made for sleep they're pharmaceuticals that act like melatonin. Melatonin is a hormone that's made in your pineal gland. Everybody makes it every day. And it follows your biological clock. It helps your brain know it's time to rest. And very small doses, even, while people often take much more than this, but as a sleep aid, are very good for MS. People's sleep is much improved, their quality of sleep with doing this. It's been demonstrated recently fairly conclusively. And so it's very safe. It's also good for your skin. A lot of people take it because it makes their skin look better. It's very, very safe. You don't want to know where it came from, but it's good for you. All right. Came from some other animal's brain. So let's talk about medications. So my PhD's in drug science, and there are a few different kinds of medicines that we use sometimes to help people's thinking. First of all is one of them that we associate with improving people's walking. This drug, dalfampridine, used to be called Ampera. It used to be called 4-aminopyridine, which is bird poison. So they changed the name so people wouldn't get them mixed up. We wouldn't want you to get your medicines in the hardware store and take too much poison. But it wakes up the brain. It makes the nerve cells more excitable. That's how it improves walking. It improves strength. It improves coordination, and it improves thinking in some people. It's a twice-a-day medicine. Very rarely it'll cause an epileptic seizure. But other than that, it's a great medicine. There are some we call non-amphetamine or non-narcotic stimulants. They're treated as scheduled substances, modafinil, and the newer version of that was armodafinil. It's not formally approved for MS, and insurers will often refuse not to pay for it, but you can get them for $40 a month with a coupon, and just realize that just because your insurer says, we're not going to approve that, or we're going to limit that. If you have sleep apnea or you work shifts, they'll pay for it, actually. And sometimes if you have bad depression, they'll pay for it. But if they don't, it's fine. Just get a coupon. You go to the pharmacy that takes the coupon. Go look at some of these discount plans. Don't ask one of the big pharmacies to give it to you for cash because they'll overcharge you horribly. It's kind of shameful. But these things, basically, this is like caffeine without the jitters. You will not fall asleep. You will stay attentive. They give it to fighter pilots to keep them from wrecking, $10 million aircraft. There's a medicine that's used for older people. Actually just got approved also in a patch form this week. It's called donepezil. It actually boosts memory. Some young people like it because it helps them study for exams, perform better on tests. It's pretty safe. There really is, other than some stomach side effects in an occasional person, there's no problem, and it's a very simple way to enhance the efficiency of your brain processing. There's an antidepressant medicine called bupropion, Wellbutrin. As long as you don't have epileptic seizures, it promotes attention really well as elevates mood. And it boosts the go signal in the brain as part of how it works. Another family of medicines that boost the go signal has more abuse potential and is controlled, and it also has more side effects, and those are amphetamines. The simplest, safest amphetamine is a diet pill called phentermine, and it can be refilled. The others are ones, they're often given to children for attention deficit disorder. And unlike what you would think, they make kids sit still. They don't make them go faster. They make older people go faster, wake up. But it can also make people irritable, and they can lose too much weight. Bupropion actually makes people lose some weight too. But they don't work that great. They make people more awake if they're really sleepy, but they don't make their brain, there's some evidence that in people with MS, the brain's already working really hard, and making it work harder, turning it on more doesn't really help because it's already turned on a lot. So that may be the reason why it doesn't work as well as what you would think. And there's also limits due to the safety. It raises blood pressure, it raises heart rate. You might be inclined to hit somebody who disagrees with you, things like that. It's more of a good thing, isn't always better. So let's talk about MRI, because that's one of the ways we measure MS. It's very hard to get MRIs that are done to the same standards that are recognized internationally in the U.S. Why is that? Well, basically, centers get paid to do it the same, whether they do it really well or really badly. And if you do it badly, it doesn't take as long. So that's a financial incentive. Now, your neurologist can be very insistent with the centers that they work with to try to get them done right. What don't they do right? The biggest problem is they issue reports that are not very informative, and they do pictures which are not very detailed. It takes time to get really good pictures. And so what a center will do who wants to save time and money is skip large parts of the brain, do very large slices so you can't see smaller lesions. And the problem is people on treatment, smaller lesions are what are new many times. And changes in the size of lesions you cannot detect if you're skipping areas and if you're using large volumes at once. The newer machines have ways to avoid that. The older machines, it takes time. Seeing things in the lower part of the brain, the spinal cord, is particularly difficult, and special ways to do that are required. Many centers use a one-size-fits-all protocol that's appropriate for people who have neck pain or back pain that don't see the MS lesions well. And so centers that do a lot of imaging for MS patients and who take pride in the quality of that imaging are really important. We look for the number of spots, whether they're new, whether they're enlarged. We try to get some estimates of comparing the volume of the brain over time, which is important. And really, you can either have a very inexpensive scanner where they spend a lot of time doing it and get really bad pictures, or a really expensive scanner that's very powerful that they do a very bad job with. So just because they have a number on the magnet that says it's a more powerful magnet doesn't mean they do a better job at MRI, unfortunately. All right. I'm sorry, this slide is pretty small. I'm just going to talk. It's mainly notes for me. But it's how to get care with MS. And MS is a neurological disease. Very few other specialists are going to be good at caring for it. However, there are aspects of care that are really important. I'm going to talk about some of the specialists, and we'll talk about primary care in a minute here. But neurologists are in a short supply and getting even less. The doctors who do a lot of MS usually are older. Many of the doctors who are coming out of training are being brought into hospitals to work because the hospitals are desperate and can't function. They can't meet government criteria for operating without having a neurologist. And so basically, they'll pay so much for them that these younger people can't resist, and they don't do outpatient medicine. It's very hard to do both, and they may never learn it either, where many of the older doctors are people who for many years have cared for MS patients. The younger ones may or may not have that experience. So someone who does a lot of MS, if it's a neurologist who does a lot of MS, that's better than one that doesn't. But I will tell you that across the world, half of the neurologists do not want to see MS patients. They consider them a lot of work, and you are a lot of work most of the time. So you need to be aware of that most neurology practices are not set up to do everything that you would like to do. And you need to work with the resources that are available to you, so you try to limit to one problem a visit and get in there regularly if you want to get anything done. The other specialties which help MS patients a lot, and we'll talk about primary care separately. If you have access to what's called a physiatric care or a physical medicine rehabilitation, these are great doctors. You can't find them anymore. They're in specialized centers that do rehab in hospitals or pain management sometimes. There's not many of them, but they're very, very good at helping people who have disabilities. They're better than most neurologists are. The urologists or bladder specialists, there are different ones. All urologists know the basics of how to do this, but many of them really, they deal mostly with men, or they don't want to see women unless they have kidney stones. They really like kidney stones. But you probably don't have kidney stones, and they don't want to deal with your bladder issues. And bladder health is really important in people with MS. It's somewhat complicated. Most neurologists don't know how to deal with it. Most primary cares don't know how to deal with it. There is a group of gynecologists. The average gynecologist is not bad, usually at dealing with bladder issues. And they're a specialized group called urogynecologists. They're not urologists. They're trained as gynecologists. They do some of the same things that are actually quite interested usually in solving your problem. Psychiatry is important if you got a mood problem that's not satisfactorily controlled. The most important thing is you feel like yourself. And there are mental health providers who can very quickly try a lot of things. You're not going to get that from your neurologist or primary care. You may get a couple of attempts, but if that's the big problem, you want to get help for it. All right, let's talk about primary care and things you need to do with the MS patients. First of all, the most important thing is undertreated high blood pressure. People come to me all the time and they say, well, my blood pressure is only a little high. It's not a little high. It's only high when I'm in doctor's office. That's not true, I guarantee you. My doctor doesn't think it's bad enough to do anything about. He's wrong. Get it treated. Okay? The longer your blood pressure is high, the more it damages your brain. It affects your MS. It predisposes you to heart attacks and strokes and kidney disease, all of which are going to make your life miserable when you get older. Get your blood pressure treated. It should be normal. It should be 120/75. If it's not, keep working at it. You know, bladder infections. People with MS get a lot of bladder infections. It's very helpful to have somebody do it. Neurologists aren't going to do it. So urologists, if you have one, will usually help. And if you're having a lot of them, they're going to usually try to solve the problem. Cholesterol. Why is cholesterol important? Cholesterol is something that's going to cause you trouble down the road. But the really nifty thing about cholesterol medicine is it's very good for MS. And we don't know yet how to use cholesterol medicine as neurologists for multiple sclerosis. But we're getting there. There have been several experiments done. And it appears that the cholesterol medicines for MS are one of the most effective ways to slow down MS getting worse. Can you hear me okay? Okay, all right. Obesity. Obesity helps cause MS. Obesity is a state where we're fed well enough that we have a lot of weight around our waist and it turns on our immune system. We don't understand why. Obesity also, if you're carrying enough weight, wears out your muscles and your energy, and people who are overweight have much more disability than people who are not. I have thin little people who float down the hallway, and when I test them, they're actually quite weak, but they can still walk fine. And I have other people you can barely tell they're weak, and they're heavy, and they're moving so much weight around, they're really quite limited in what they do. There are wonderful ways, simple ways, to lose extra fat that you're carrying around your waist. Your health will get better, your disability will get better. There are medicines now that help a lot. You can count your calories for free on an app called MyFitnessPal. Diabetes is what ends up happening. Basically, hypertension, high cholesterol, obesity, diabetes, and liver stress are all the same disease. We call it metabolic syndrome. We treat them as different diseases because you have to break them into problems to manage them. But those are all things that are going to happen to somebody who's got these typical health problems that we have from being overfed and under-exercised. And people with MS have a real problem with the exercise part. Thyroid dysfunction, that's a common problem with MS. It's usually surveilled by primary care. A neurologist will sometimes surveil it for you if you're in their office. But a healthy thyroid function is good for your brain. The brain loves thyroid hormone. Vaccinations, we're going to talk more in the later part of this talk. And then communication between your neurologist and your primary care is very important. And if you can't make that happen automatically, take notes from each one to the other when you go, so that they have the information. It makes a world of difference for the doctors to do that, and there's no way that they can sit down and do that systematically. All right, what about telehealth? That's been very popular during COVID for safety and convenience, and it's probably going to end mostly this year because insurers will say, okay, we're not going to pay you a regular visit anymore, we'll pay you $10. It will stop because you can't get the job done for that kind of cost. Neurology is really hands-on specialty. If your doctor doesn't touch you, he's not doing his job, or she. What it can do, telehealth can decrease your travel and access for medication and laboratory and getting those things done, coordination and care. It cannot assess you accurately neurologically. There's no way. You can't even come close. I've seen really dangerous things happen in the last couple of years to people because you just can't properly assess people. Doctors are trained on how to assess people who are in front of them and that they're touching and watching. You just can't do that remotely in any kind of meaningful way. All right, let's talk about new things. How am I for time, Stuart?
Far behind.
I'm far behind. You mean I should be stopping?
No, you need to, well, you're going to be stopping in about 15 minutes.
Okay, that's fine. That's where I am. All right. So let's talk about new medications. It used to be they were few and far between. Now they're coming fast and furious. Some of the medicines have gone generic. They aren't necessarily cheaper to you when you go generic. Insurers may demand you use them. I suggest where it's reasonable to use them that you try them, because it will open up more opportunities for you with other medications. The class that's got generic members in it right now is called methyl fumarates. Tecfidera was the brand name drug. It went generic. It's called dimethyl fumarate. Last I checked, you can get it for $125 a month from Kroger or Publix with a coupon. It still has a very high copay, and there's no manufacturer assistance for a generic drug. So if you go to the specialty pharmacies, like you've been getting other medicines from, they may quote you a ridiculous copay, thousands and thousands of dollars. $125 a month with a coupon at Kroger or Publix. If you can take that drug and it works for you, it's a very safe drug, very pregnancy friendly. But if you can't take that drug, a lot of people can't take that drug because it upsets your stomach to the point of being an allergic reaction. There are in that family, there's two brand name drugs, Fumarate and Bifirtam, that are better tolerated with copay assistance. You may or may not be able to get your insurer to cover it. There are now 4 medicines in the S1P family. The old medicine, Gilenya, which was hardest to start because of the requirement that people spend a day there, is going to go generic in a couple years. The second medicine that came, which was really designed more for higher disability people, needed a genetic desk, has turned out to be very frustrating to get restarted because the company absolutely refuses to pass out samples to physicians' offices and easily to patients to restart the medication. And we have to deal with these so-called specialty pharmacies that you've learned to, you know what you've learned about them. Okay. Every time you call, and we can't get it restarted when somebody has a treatment interruption. Somebody's off the drug for 4 days. They have to start over with a dosing pack, and we can't get the dosing pack. We can't get the pharmacy to send us even the pills so we can tell people how to do it. There are 2 new players. Both of them are out here today to tell you about their products, Zeposia and Ponvory, that are much improved in terms of their tolerability and their ease of use. Zeposia, which has been out for a couple years, there are some education about foods and medications that have warnings on them. And Ponvory, it is probably the quickest of our medicines in this family out of the gate to start. It is very pregnancy friendly, and it doesn't have as many food or metabolism issues. Both these drugs are sampled in doctors' offices. So if there's a treatment interruption, you often can get help immediately and while you're trying to solve that with your pharmacy and your insurer. The older medicine, Aubagio, is about to go generic this year. There's an older medication if people absolutely have an intractable financial problem and they just can't get anything else done and covered or paid for. There is a medicine that's related to Aubagio called leflunomide. It is used for rheumatoid arthritis. It becomes the same medicine in the body. And some MS doctors will use this medicine for people who have this situation where they just can't tolerate or get anything else done, and they can't afford it. And you know, the Medicare copay, if you're on a Medicare Part D for all brand name drugs, is many thousands of dollars a year, and it's now very hard to access assistance for those. All right. What about really high-powered MS medicines? These are mostly IV medicines or injectable medicines, not the older injectables, but newer injectables. And we don't call biological medicines generics. We call them biosimilars. It's like saying, you know, 2 chefs don't cook their chicken the same way. With other drugs, they're chemicals, basically. They're identical. But with biologic medicines, every company has to test their drug and show that it does what it's supposed to do. The family called anti-CD20, like what's been around for the older medicine that wasn't approved for MS, but sometimes used, called Rituxan. And the newer one that is approved for MS is called Ocrevus. There are two newer medicines. One's been approved and on the market. You've seen it advertised on TV with those people that look like they don't have MS. And all their problems have gone away. But Kesimpta is a very well-tolerated drug. They've both been shown to be superior to Aubagio. Ublituximab is one it has a brand name drug. I don't remember what the brand name is. It's not approved yet. It is a very quick infusion, and it's coming probably next year. So there was a biosimilar of Tysabri that's in the works from another company that's like Tysabri, and there's a Tysabri injectable, which the government said, we don't think we're ready for this yet, but it might be here someday. So there really is nothing else new coming for the next 4 years. And most of these things are like Me Too strategies. So there is a family of drugs that is very large that 5 or 6 companies are racing to test in MS. That it works in MS, there's no question. What the difference between it and our current medicines are is yet to be known. Whether there are any unexpected adverse effects, we don't know yet. It's basically an anti-inflammatory medicine that's not like steroids. And we could have new medicines in this family in the next 4 years. And they're extremely well tolerated. We'll find out. As far as other new ideas, there's some really wild new strategies that have been tested for MS. There's a company called Neurone. That's the way they spell it. It's cute. That actually did a study with injecting highly engineered stem cells that are engineered to make signals to the brain that help the brain repair. And they inject them in the spine of people with progressive forms of MS, and they improved. And it's pretty phenomenal. Whether it's actually going to work when they do it again, we'll find out. There's another study with a completely different strategy that was tested in people who had progressive forms of MS. That's where they give people T cells that are engineered to go after the Epstein-Barr virus infected cells that aren't making virus. Our immune system normally can only find the ones that are making virus, but it goes after the ones that are being stealthily controlled by the virus. And that it's not making virus, but it's controlling a cell. These zombie cells are targeted by basically a donation of T cells, which go and kill these cells in the immune system and anywhere else they find them, whether the immune system or not. And people have improved very significantly who've gotten these treatments. There's studies going on. If you go to Nashville a lot and you have that, call me. We've got a study. There are other very interesting things. There's one with gold nanoparticles that seems to improve animals that are working. I've got some very early level studies that we give people a few doses, and it seems to calm down the immune system for a long time. Volunteering for MS research is important. It's one of the kindest things you can do for yourself and everybody else in the world. I call it donating your body to science while you're still alive. If that's meant to be a joke. Yeah. I should make a T-shirt that says that. All right, let's talk just real quickly about vaccination. Vaccination is really important. People get very concerned about the safety of vaccination. If it makes it to market, it's generally a very safe vaccine. And vaccines that weren't safe aren't really used in the United States anymore. There are vaccines that actually do cause disease. The best example is the chickenpox vaccine. And once in a while, you give somebody a chickenpox vaccine and they get the chickenpox from it because it's the chickenpox. That's what the vaccine is. But it's a mild version of it. And there are older vaccines. And the one vaccine that patients with MS should never get is the yellow fever vaccine. Yellow fever decimated this city back in the 1880s, killed off many tens of thousands of people. But yellow fever, the vaccine is not good for people with MS. It can cause MS-like problems even, and it's especially for older people and people with weak immune systems. The virus that's in the vaccine is just too strong to give to people who have MS. Vaccines don't really change your DNA. They train your immune system. Your immune system actually edits this DNA to make it better at getting rid of viruses. So the way the immune system works is once it sees something, it has a response. And these responses are called IgM and IgG. IgM is the first one. It's a sticky antibody, and IgG is a more directed antibody. It's like a guided missile. And it comes, and then if the stimulus is gone, it goes away. But it's actually, it's got cells that are trained, and when you see it again, it comes back very quickly. They know how to do it, and you get a more lasting response because you keep making more cells that know how to respond. This is how the immune system works in vaccines. This is how the immune system works with infections. Yep. Is it going to go? Doesn't want to go. Oh, there it is. All right. It's just slow. There are guidelines online. I'm not going to go through all the guidelines from the CDC, but if you go to the CDC website, it tells you everything you need, and there are vaccines you need throughout life. What kills people with MS is pneumonia. Make sure you get the pneumonia vaccine. There's a new one called Prevnar 20. It's basically got 50% more coverage to the bad pneumonias. All right, most of these common vaccines have been tested in MS patients. Actually, there are patents on using vaccines to reduce MS relapses. They seem to do that. But vaccine adverse effects like fever, joint pain, and headache can certainly worsen your MS symptoms temporarily. You should take aspirin-like pain relievers religiously around the time you get vaccinated. Live virus vaccines, of which there are only a few, the polio vaccine if you're a child, if you haven't gotten it, the chickenpox vaccine, which you need at least one dose as an adult if you had one as a child, or you need 2 doses as an adult, and the measles, mumps, and rubella, which hopefully you've gotten multiple times because it's a really bad virus to get. You should get these before you have treatment with stronger MS medications, or you should take a break from treatment. Some of these medicines that last longer, like Ocrevus or Limtrada or Kesimpta now, you have to wait for those to wear off to get a live virus vaccine. It's not a good idea. And with the S1P agents, you need to be off them. Some of them you can be off just a few days before you get the vaccine. But the benefits of vaccine far outweighs their risk to you as MS patients. I used to say, patients with MS don't die from viruses, and then COVID came. And we lost a number, not a lot, not really, probably more than any other situation, but it does happen. But people with MS have genes that deal with infections, and actually, surprisingly, their genes deal with infections very well. They have very aggressive responses. These genes that led to MS are actually genes that probably kept your ancestors alive. And some people are more prone to serious infections than others. Some people with MS have weak immune systems, just like everybody can have a weak immune system. But the people who with MS, they die from pneumonias more than any other cause, and other serious infections they get are things that affect, they can be foodborne illnesses like salmonella or listeria, or just things that sicker and weaker people get, like Klebsiella, can come from the bladder or the lungs. People with MS are on a lot of medicine. Some of them are technically immunosuppressed. People with MS get shingles, which is the chickenpox virus. We call it BZV in medicine. It lives in your body. There's a vaccine for that that's used when people are older. PML, we'll talk about here a little bit more, but PML is something that happens to a tiny, tiny, tiny number of people with MS, and generally they're people who are treated with Tysabri. The other sorts of problems are really quite rare unless people have received very aggressive suppression in their immune system. PML looks a lot like MS, but it's not MS. It can involve different parts of the brain. This is probably a patient on Tysabri, judging from the doctor that gave me this slide. And it basically is a brain-eating virus. And you didn't catch it from somebody. You've had it your whole life. You picked it up from a bathroom or somebody's hands, and eventually it just changes into a version that can eat your brain. And if your immune system can't get into your brain, it is not good. And it's a catastrophe. This is the biggest reason that we don't use Tysabri much, because the risk is over 1% a year of that happening. All right. But in general, viruses in MS, people with MS get the same viruses as everybody else. They actually have more serious childhood viruses, or at least they used to before we had vaccines for them all. And as adults, they say, I never get a cold, or I don't get very many colds. But deaths from viral infection MS are really exceptionally rare. COVID-19 was new. This family of viruses has been around a while, but this one's different. It had an astonishingly high death rate in older people that is evolving, of course, into milder variants, which is what viruses usually do, but you never know when a bad one's going to come around. It does seem to have a very low risk to children. It's remarkable how common illnesses in older people are the principal factors. N95 respirator masks are really the only effective mask. Those are very hard to wear. They're more expensive. It's in the air. You get it from breathing it. It's very hard to hold your breath. For very long. That does work. It just doesn't work for very long. The thing about immunity is, while vaccines mitigate the severity, the immunity really wears off about 5% a month from the vaccines. So they're a temporary strategy. I entirely expect that we're going to continue to get vaccinated periodically. But the risk of the vaccine is really, these are extraordinarily safe vaccines, but although there have been rare, very serious complications, it's thousands of times less chance that you're going to die from the vaccine than from the infection. There are now antiviral medicines that you get, that you go to a pharmacy and get and make it better, just like there are for the flu. There are ones that are only given in the hospital. There are antibodies that help prevent it in people who are at really high risk, who have very weak immune systems. If I was going to advise you to do something, it would be build a team of people to support you. You may have very well-controlled MS, and you are the team, and the doctor who's prescribing for you, or the nurse practitioner. You want to maintain your whole health. Don't neglect the other health. Get your gynecologic exams if you're a woman. If you're older, you need skin exams also with a dermatologist. You want to watch for cancers. The most important things are you get up and you move, you eat healthy, and you manage your MS. And we want you to live a long, long time. And most people with MS will. People with MS live a very full life now. And we want you to keep walking, too. All right, I'm going to stop there and let Stuart.
Thank you, Dr. Hunter. Everybody want to thank Dr. Hunter? That's great. All right, let me take this off for a minute. Again, we're going to take questions online. I'm going to be running back and forth to the laptop. I'm going to be running around the room as well. Please make me run, all right? I want to see your questions.
I have had MS 18 years, and I'm on Vermidity now. So I'm trying to see if that's the best the best medicine that I'm on.
I'm sorry, I didn't catch what medicine you were taking.
I'm on Vermidity.
Oh, Vumerity, yeah. So let me tell you, we have basically left behind a lot of the older medicines that were the interferons and the glutathione acetate, not because they weren't good medicines, it's just we have better. And so we have 3 families of medicine that we go to now, and Vumerity is in this one we call methyl fumarates. And the methyl fumarates that are on the market, of which there are generic ones called dimethyl fumarate, which was previously called Tecfidera. There's Vumerity, and there's another one called Vafirtam. These medicines all act inside the body exactly the same. They got approved because they're all work just like Tecfidera. In fact, they're indistinguishable inside the body, but they're different outside the body, so they're called different medicines. And Vumerity I would say is probably the best tolerated of them. People can seamlessly switch between this family of medicines, and they are more effective generally than the older medicines for MS, than the injectable medicines. And when people are well controlled and their immune system doesn't get knocked down excessively from the medicine, and people can take the medicine twice a day, which is that. Usually they take it with food, and they're not bothered too much by the flushing that can occur or any stomach issues that can occur with them. It's an ideal medicine. And the hardest problem is just getting it approved with an insurance company because it's a brand name medicine.
Thank you for that. Next question's here.
What do you know about Mayzent? Mayzent, I know that's a fairly new drug.
Mm-hmm. So again, this is one of the 3 heavy lifter groups of oral medications. They're called the S1Ps. Mayzent is one of the sphingosine 1-phosphate modulators. Sphingosine 1-phosphate is a signal that cells make when they want to turn on inflammation. And this family of medicines, which the older medicine is called Gilenya or fingolimod, the second medicine was Mayzent or siponimod. It requires some blood testing when you're going to start it in order to be sure what the dose should be for you. And there are a few other rules about what you do with it. And it gets working pretty quickly, but if you get off it, it stops working pretty quickly too. And you heard me belaboring the point that it's really hard to deal with specialty pharmacies to get the medicine to start it over again because the company doesn't give out samples, which is a little bit unbelievable, but that's not been a problem we've been able to solve. But Mayzent was actually shown to work effectively in people that we previously thought were very hard to treat MS patients, which are older people who are having trouble walking and don't have as many relapses. And that was always thought to be people who didn't respond to treatment. And they were able to show with Mayzent that those people were benefited by treatment. So that's Mayzent's part of these S1Ps. We have these 2 other members of the S1P family that are newer that were tested in younger relapsing patients, Ponvory and Zeposia. But so there are gaps in what we know about what's right for everybody. In general, that family of medicines, we try to make sure that people don't have major eye diseases and that people don't have any kind of major heart rhythm disturbances before we give them.
Dr. Hunter, there are so many medications available for MS now and more coming. How can people know, and will people ever be able to know what the best medication is for them to take?
That's a very good question. And what I generally tell people is we skip the old first-line medicines unless we really need them, because we want to go for drugs that are more effective. And these 3 classes of drugs that are out there now, that there's an injectable medicine called Kesimpta that's like Ocrevus. There's the S1P medicines that we were talking about, and the methylfumarates. And I think that it's kind of like what the doctor thinks is the best choice as the first medicine for MS is usually going to be one of those families of medicines. And the second choice is probably going to be from those family of medicines. But if you really need more efficacy than those medicines, then the medicines that we call biologics, which are like Lemtrada and Ocrevus and Tysabri, are the ones that, if we really are having trouble controlling the disease, that we'll go to.
I was diagnosed in 2008, and about 5 years ago, my walking started declining, and now I'm on a scooter. But whenever I have an MRI, she says I don't have any lesions on my spine. All my lesions are on my brain, but not on my spine. But my walking, I can't walk anymore.
Well, this is a very frustrating situation, and there are several reasons for it. Sometimes it's one very small lesion that's causing the trouble. There's a place in the brain where all the control of your arms and legs crosses right at the bottom of the brain. It's very hard to see without special techniques on the MRI. And oftentimes the other lesions are small and they're not real obvious. And the manner in which the pictures are done, they don't see any bad lesions, basically. But there are a number of smaller lesions that add up over a long distance. Just like people standing on a fire hose, eventually you can get enough people to stop the flow of the water. It's the same is true. That slip in function is what we call the progressive MS pattern. It happens, people sort of tip over and they start having walking problems, and it just gets worse over a period of years, a very rapid decline. And the best thing people can do who have that problem is to try to keep moving as much as possible, because even being able to walk a couple steps is better than nothing in terms of being able to get your life done.
Can MS affect your body's ability to regulate your body temperature?
This is a good question, and the answer is yes. And so can medicines that people take for MS, all right? So the most common reason people's body temperature regulation is off is because their hormones change as they get older. But people with MS are more likely to get heat stroke for several reasons. One is they often don't sweat over their whole body. They sweat in a few places. They'll say, "Oh, I sweat so much," and I ask where they sweat, and it's all in their head. They don't sweat well in their feet or their trunk, and so they're prone to get overheated. The other thing is medications that cause dry mouth also stop sweating. So it's very easy to get hot, and people with MS die from heat stroke. I have a lot of people who go out in the sunshine and get to a pool or to a ball game, and they get dangerously overheated. It's very easy to do.
Thank you. Next question will be from online, please. And that is, the person writes that they had the pneumonia vaccine in 2009. Should I now take the Prevnar vax?
Yes. Okay. So the old pneumonia vaccine is still around. It's called Pneumovax 23 now. It was originally called like Pneumovax 12, and now it's 23. And if you're over 60 years old, you should get Pneumovax again, the Pneumovax 23. The Prevnar is a once in adulthood vaccine, and if you didn't have the new Prevnar 20, you should get the new Prevnar 20. It produces a much better response than the older Pneumovax does to those. They're polysaccharides. They're basically from strains of these pneumonia. And these organisms don't just cause pneumonia. We call them strep pneumoniae because they do cause pneumonia, but they cause other kinds of strep infections too. Not all the kinds that we call strep, but some of them. And they give these vaccines regularly to small children, and they're much healthier than they used to be. But this Prevnar 20 is a real big advance, and it covers more than 50% of the bad pneumonia strains that happen. And so it's a yes, and it's only one time you have to get it. But you should also, if you got the Pneumovax before, you should get that one again too. You don't get them at the same time. You can separate them by 6 months.
Okay, the next one is from another person online. And normally I don't say these people's names, but Coy deserves her name to be said, so I'm saying Coy, all right? And she asks, why is short-term memory usually affected, but long-term memory stays in place?
Well, we think that memory is connections between nerve cells that are distributed throughout the brain. And because you can do a lot of things to the brain and people still have their memory. And so the problem is making new memories. The more things are different, the more likely you are to form a memory. And it's a lot of work for the brain to form a memory. As we get older, that's not as good. And short-term memory means you can remember where you parked your car or what you made for breakfast. It's something new that's changing, and the brain doesn't record everything. It's kind of an illusion that we remember things well. We actually remember pieces, and we just kind of put it back together when we start telling ourselves the story. But it's much easier. A single dose of a sleeping pill can make you forget things for hours, and not people don't realize this. They just don't remember it. So we have people all the time who said, I recorded myself walking all over the house. I was sleepwalking. And you weren't sleepwalking. You just don't remember what you were doing. You weren't making memories while you were taking those sleeping pills.
Thank you. Next one online, and then I'll go back to the in-person audience. And this is, are those of us with cog fog more at risk for dementia or Alzheimer's?
Well, the good news is we don't think people who perceive trouble with their concentration and performance are more at risk for dementia. Dementia is a problem that's caused by a goo in the brain called amyloid beta, and there's now treatment for amyloid beta, and we see a lot of our MS patients who really do develop bad memories, and some of them are getting Alzheimer's disease. But Alzheimer's disease is something almost everybody gets if they live long enough. So it's really to say that you're not at risk for Alzheimer's disease, well, you are, but just not yet, would be the best way to look at it. And there are tests. Unfortunately, it's a spinal fluid test. If you want to pay for a blood test, you can get a blood test that will tell you if you're developing Alzheimer's disease. That is a fairly reliable test, and there's a special kind of imaging with a PET scan that you can also get that's unfortunately not covered well by insurance and is quite expensive. But patients with MS don't need to worry usually about Alzheimer's type changes. They're far more affected. Our biggest problem is medications and people having that affect their memory. I've had so many unpleasant conversations with people who are wedded to certain medicines that are impairing their mind that I just can't make. I'm just going to say, I'm not going to prescribe that for you anymore. We're going to get you off it. And I have to listen to incredibly unpleasant, opinions of my abilities about trying to save this person's brain because of that. But medicines are very powerful at impairing memory. Sometimes people have seizures, and about 10% of MS patients, when you look at their brain waves, they look like they have seizures, and sometimes that's what's scrambling their thinking. We routinely evaluate that. It's a very simple test. It's like an hour. We do an hour EEG with a nap, and you can see if the brain's got this abnormal electrical activity. It's associated with what we call simple or complex partial seizures.
Next question.
Yeah, as it turns out, this is possibly a follow-up to that short memory question you had. Any research or recommendations about the class of drugs like Prevagen to maybe help with that? Yes, no, can't hurt,
So if you ever hear the word Prevagen, you can say, don't bother. A famous neurologist many years ago said, if you ever hear someone say they have a treatment for MS, say BS and you'll always be right. Well, if you ever hear Prevagen, you can say BS and always be right. The government's been trying to stop that company for years, and they just make so much money off it. The lawyers keep the government tied up. It doesn't work. Using your legs works. Some diets may work, things that are ketogenic diets, eating healthy and fish and things may work. Coffee has some big benefits in older people with memory loss. It's quite remarkable. Folate and B12 are very important. Many people with MS develop B12 deficiency and don't know it, or their doctors don't know it, because B12 deficiency looks a lot like MS, but it's another immune disease, and it's really not rare. If you have a low normal B12, you ought to go on supplementation before it does get low and damages your mind.
What are your thoughts about pregnancy? Because I was told by my doctor that pregnancy or getting pregnant would worsen my symptoms.
I love babies. That's my thoughts about pregnancy. No, that is an old idea about MS that we told people 40 years ago because people had relapses after pregnancy. And during pregnancy, after the first few weeks, generally people have no MS symptoms and they feel great. Some people near the end of their pregnancy or short after, about a third of them will have an MS relapse. It's actually safe to use steroids to treat relapses in pregnancy. It doesn't harm a child. The most pregnancy-friendly medicines are the older interferon beta and glutathione acetate, and the other is the methylfumarate family. Are very safe. People usually take these things until they conceive. Sometimes they start them again before they deliver or immediately after delivery to reduce the risk of a relapse. But there is absolutely no evidence that pregnancy produces any long-lasting problems in multiple sclerosis.
Question over here.
In your earlier slide, you referenced Tysabri being a drug that was aggressive, and we know it is. And that some years ago, I remember there being a limit or something like it on how long a patient should take Tysabri. Is that still the case today?
Well, the limit is in its professional opinions about what the risk is. And so if someone has life-threatening MS and it's controlled by Tysabri, please take Tysabri. In Vegas, if you said you have a 99% chance of winning, that's a safe bet. And that's the situation with Tysabri. But the losing is very ugly with Tysabri, okay? The PML is a disaster. It's a catastrophe of epic proportions to people with MS. And so the question is, do you need that kind of risk in order to manage MS effectively? For most people, the answer is no. People feel great on Tysabri. It works really well. If we didn't have this PML problem, we'd probably use it for every other person with MS. But because of that, there is not an easy way to control the risk. We can estimate someone's risk. Some people have less risk than others. But the facts are that everybody has risk who takes it, and it's just a question of how much. And the average person after 5 years has got a 1 in 20 risk of getting it in the next year. And it's a risk that most people don't need to take.
Do the new meds have, is there any research that you know of that shows the new meds have a lifespan of how long they should be taken?
No, there's actually no other data, and most of them have at least 10 years of patients taking that family of medicines or more. And we know what the approximate risk is for those of life-threatening problems, and it's extremely low.
I'm currently on Ocrevus. I went for my third infusion on Monday. I want to say 2 days after the infusion, I don't know what to call it, but I was feeling bad when I went in. Once I finished, I was feeling much better. But after those 2 days, I went back down again. Is that normal?
Well, so people with MS who aren't walking well are very sensitive to their body temperature changes. And sometimes as a side effect of getting a treatment like Ocrevus, because it goes in to clean out immune cells, it activates some parts of the immune system temporarily. People often experience this as body aches, headache, or flu-like symptoms for a few days. It's often associated with the body temperature going up some, and people will do that. They may get a dose of steroids while they're getting it that knocks it down temporarily, so this instability happens. Generally, those things iron out over time, but it's something you talk to your doctor about. But some of these family medicines have much more dramatic events. You know, it doesn't necessarily mean anything bad, but people with vaccination, for example, who get vaccines will tell me they were really sick for a couple days sometimes with their MS. And it's because the immune system's just doing what it does when you get a vaccine.
Okay, thank you. Over here online, please, we have a few quick questions, and I'm going to need a few very quick answers, okay? All right, the first one is, again, what are the two types of medications that are safe to use during pregnancy?
There's actually three.
Okay.
And then everything else, it's a risk-benefit assessment. But the older medicines, interferon beta and glutathione acetate, things like Rebif, beta-seron, Copaxone, and then the newer medicine that's safe in pregnancy is the methylfumarates, which are Tecfidera, Vimerity, and so forth. The dimethylfumarates are very safe around pregnancy. And it depends on how bad someone's MS is whether you're going to use anything else. But the drug that's very unsafe in pregnancy is Aubagio and any kind of chemotherapy medicines.
Okay, thank you. Next one, are second COVID boosters recommended yet for people with MS?
Well, first of all, people with MS were actually not supposed to get a booster. They were supposed to get 3 doses of vaccine. They weren't considered boosters, and they can be given in close sequence to each other. They don't have to wait. They're about to offer another booster to anybody over 50 in general. The recommendations have been made that people with immunosuppression have 4 doses, but it's not been formally implemented.
Okay, thank you. Next one, how often should a person get an MRI with contrast?
So first of all, this is, I assume the question is related to, because of the contrast safety issues. The currently used newer contrast dyes are exceedingly safe. Don't worry about them. The only people who have an issue with contrast are people with very poor kidney function. We're talking about approaching levels where you're going to need dialysis, and they will make sure that they don't give it to you if that's the case. The older contrast dyes do leave some of the chemical in the brain. You can see it on older patients who've had a number of MRIs before. It seems to cause absolutely no problems. So that said, MRIs are generally done with contrast every time somebody with MS gets an MRI of the head or spine, because it's very important to identify if there's active MS activity. If someone's having an MRI done for another reason, like they might have a stroke or they might have a back pain problem that they're looking at, those may be done without contrast.
Thank you very much. Next one. Can a person that's doing an Aubagio washout get a COVID booster?
There's no problem with getting a vaccine when you're on Aubagio. It is not a risk. Aubagio is a medicine that doesn't have any significant infection or viral risks. There's actually a lot of data that it's probably in any viral medication.
What can you tell us about medical cannabis?
Well, it's not legal in this state yet. It might be someday. There's something called Delta-8 THC, which is actually cannabis that's legal for the moment, but won't be legal very long in this state, because they've realized it's just basically the same thing as the active component in marijuana. The brain doesn't know the difference. That said, cannabis that's smoked is a very large dose of the intoxicating agents. It's very bad for people's thinking. If you want to pick one thing that's worse for your thinking than anything else, I guess drinking alcohol all day long would be worse than cannabis, but cannabis is terrible for your mind. I think it's a risk-benefit decision for medicinal doses. There are medicines that are approved in other parts of the world that are basically cannabis-derived. In Canada, you can get a spray that is a combination of CBD and THC that it does alleviate the symptoms of spasticity. And the company that's trying to get that approved in the United States has tried for over a dozen years, and the FDA is still not having it, so it's not coming soon. That said, are small doses of THC a problem? Yes, those are probably fine. They've tested it for MS. It doesn't work very well. It probably works a little bit, and the problem is it makes people feel better, so it's hard to tell what's them feeling better. But it certainly can make people crazy, and I've seen this many times in my career, what you would call reefer madness. and I'm not kidding, out of their head in the hospital for days, with substantial doses, whether they're medicinal or they're from just homegrown cannabis. Cannabis is powerful. It's part of the system our brain uses to regulate things, and I hope that people are able to access this family of medications, because it's sometimes very helpful for folks, but it comes with a lot of risks as well. And anytime you have a powerful medicine that's not regulated properly and people don't know exactly what they're getting, it's dangerous.
When remyelination drugs become available, what is the expectation for somebody who's had MS for over 20 years?
That's a very good question. So remyelination means repairing the insulation of nerve fibers. And we know that remyelination occurs. Remyelination occurs a lot in MS, and it stops occurring as people get older. We think that that's probably part of the reason for the failure of therapies, and people start getting worse as they get older. There are things that work very reliably in laboratory settings which do not work when we test them in the clinic, or they have such tiny effects that they're obviously not worthwhile. The drug that produces the most impressive improvements of any of our drugs is called Lemtrada. I published a lot about this. About 40% of people will improve meaningfully in disability. Most of the rest are stable. About 20% get worse over 10 years. So it's a very powerful way. But it doesn't help the people who don't improve, or don't improve enough, or still have limitations. I think when it comes to lower extremity function, leg function, we're very limited in what's on the horizon. Most of these treatments have much more impressive effects at keeping people's hands and swallowing, thinking, and vision good. So there is a lot of research going on in this field. But there are still a few drugs in this family that haven't made it through comprehensive clinical trials. I worked with some 30 years ago that were so impressive they made mice dance on their hind feet. But those still haven't, after 30 years, gotten to the level of testing that we would like to have.
Thank you, Dr. Hunter. So we are finished. I got to stand here to look at this camera, right? But I do want to thank Dr. Hunter. And Dr. Hunter is going to be, you'll see and hear from him traveling around the country, doing programs with us. MS Views and News will be getting to new locations this year in rural and underserved communities around the United States, such as we're going to be going to South Dakota. And the people up there, oh my gosh, they say, why are you coming in July? It's hot. And I said, how hot is hot? Well, 75. And I'm like, that's my sleep temperature in January at night in South Florida, come on. So we're going to do like evening programs there, just so it's a little bit cooler for them. All right, so anyway, in addition to that, you guys can always find us online. All right, we do a tremendous amount of programs online. You go to our YouTube channel, you go to our website. There are people here in the audience that did not know. There are people online that did not know or do not know what I'm about to say. Yes, I too have multiple sclerosis. I use what I need to do for all of you all who are not getting the information that you need. This is how we started MS Views and News to begin with, was because people were not getting the information that they needed to learn more about their multiple sclerosis. So I use my energy that I have, and yes, I do a lot of running around the country. Prior to COVID, we were on the road 160 plus nights per year doing educational programs. All right, and I just steal your energy. So when I come to your town and you feel a little fatigued and you know I'm there, it's because I took it from you just so I could do the program that evening. All right? So I do want to thank everybody that is online. I do want to thank everybody that came here today. We welcome you. We hope to be back again within a few months to a year from now. Again, we have a very busy schedule, but we're going to help the local organization, Step by Step for MS. All right, everybody online, you heard that? There's a local MS organization called Step by Step for MS. All right, I'm hoping I'm saying all that correctly. If not, look it up. All right, and the person's name that you have to speak to is Chastity Toller. All right, she's the founder, president of the organization, and she'll be there to help you all out. Okay, so look her up. We're going to be working with her and helping to build what they do online and into different locations that they head out to. So again, thank you everybody for doing this, and I'm going to sign off right now because otherwise my video guy is going to go berserk. So saying goodbye. Bye bye. Thank you.